Today we will discuss a crucial topic for the ICU physician, which is the common causes of fluid imbalance in critically ill patients. To understand what is the common causes of fluid imbalance, we should know what is fluid imbalance exactly in ICU mean. Fluid imbalance refers to the disruption in the body's normal fluid volume and distribution, which can be manifested by either an fluid overload or dehydration. So what is the common causes of fluid imbalance in ICU? We have medical conditions which can lead to either overhydration or dehydration, medication which can cause overhydration or dehydration, environmental factor which can cause overhydration and dehydration. For the medical condition, we know in the ICU it includes sepsis and septic shock. These conditions can lead to increase in the capillary permeability and disruption in the glycocalyx, resulting in fluid leakage from the intravascular spaces to the interstitial space. Another thing that can cause fluid imbalance, which is hormonal imbalance, conditions like adrenal insufficiency and diabetes insipidus that can disrupt the fluid imbalance. Another medical cases that we know all, 3 organs that if failed, it will cause accumulation and inability to regulate fluid balance, which is kidney injury, heart failure, and liver cirrhosis. All these condition is a medical condition or a medical condition that can cause fluid imbalance. The other things that can cause fluid imbalance like fluid overload or overhydration and dehydration is medications. Medications like diuretics, we have a lot of kinds of diuretics like Lasix, metalazone, mannitol. These medications can cause over dehydration if inappropriately received. Also the IV fluids, we are considering now the IV fluids as medication. If it's used in a wrong way or inappropriate way, it can cause overhydration or dehydration. The other environmental factors, which is the third causes of fluid imbalance, like high temperature, vigorous exercise, inadequate access to water, can cause fluid overload or dehydration. Burn is one of the environmental factors. Severe burns can result in significant fluid loss through the damaged skin. Also, traumatic brain injury and traumatic injury can lead to hemorrhage and subsequent hypovolemia or fluid shift to inflammatory and capillary leakage. Also, nutritional support, both enteral and parenteral nutrition, can contribute to fluid imbalance. So managing fluid imbalance in critically ill patient is crucial to prevent complications such as pulmonary edema, cardiac failure, impaired wound healing, and there should be a regular monitoring and appropriate interventions for essential and optimal patient outcome. There is a very important terminology that is called fluid creep. Fluid creep refers to the gradual and often unnoticed increase in the fluid administration beyond the standard maintenance requirements for the patient. This phenomena is common in the ICU where multiple sources of fluids like medications, flushes, and IV fluids can accumulate over time. Also, fluid creep can lead to fluid overload and associated with negative outcomes such as pulmonary edema, impaired wound healing, as we said before. To explain the difference between crystalloid and colloid in fluid therapy in critically ill patient, we should first understand what is the difference between crystalloids and colloids. Crystalloids are solution of water in with electrolytes such as sodium, chloride, potassium, acetate, lactate, and other small molecules. They are small electrolytes dissolved in water. There is also dextrose that are dissolved in water. What is the mechanism of action of crystalloid? It readily moves across the cell membrane and distributes in the extracellular space, both the intravascular and the interstitial compartment. Colloids are another types of IV fluids that used for resuscitation in critically ill, perioperative or trauma patient, consists of large molecule which at least theoretically stay in the intravascular space for a longer duration before leaking into the interstitial space. To understand in general what is the IV fluid therapy, we should know that the IV fluid therapy include three big partitions: crystalloids, colloids, and blood products. Colloids are either natural like albumin, or synthetic like dextrans, gelatins, or starch. So what is the difference in critically ill patient while using crystalloids and colloids? The difference is fluid efficiency between crystalloid and colloid can be disclosed over time using volume kinetics. What is meant by? In past, they were telling us in our school, or in the medical school, or in the ICU medical school, that colloids can stay in the intravascular for longer time, and crystalloid can stay less time, and it will go and disappear in the interstitial. But now, using the volume kinetics and the revised Starling law, the colloid is more efficient only during infusion and during the distribution phase of crystalloid, which can be more precisely quantified by plotting the ratio between the plasma volume expansion and the two infusions. Using this typical kinetic data, the colloid is twice as effective as crystalloid during only infusion. Yani what they were teaching us before, that the colloid can give twice effect as crystalloid only during infusion, and 3 times more effective during the distribution phase of crystalloid. You know that crystalloid have distribution phase. In this phase also, the colloid are 3 times more effective than crystalloid, while the difference between the two types of infusion disappear after 12 hours. So after 12 hours of infusion, crystalloid and colloids are the same. The elimination of crystalloid fluid is greatly retarded and decreased during general anesthesia due to reduction of the arterial blood pressure. By contrast, the intravascular resistance of colloid does not be affected by the arterial pressure. This is very important. To give an example about the crystalloids, nowadays crystalloids are divided into balanced and unbalanced. Balanced means the strong ion difference of 1 liter of this crystalloid is equal or near equal to strong ion difference of the human body, which is 38. Unbalanced means the strong ion difference for 1 liter of this crystalloid is far away from the strong ion difference of 1 liter of the human plasma. The unbalanced crystalloid are subdivided into hypotonic, like glucose 5%, half normal saline 0.45% in D5 water, also divided into isotonic, like the normal saline or normal saline in D5 water, or hypertonic, like 3% normal saline. So the unbalanced are either to hypertonic, isotonic, and hypotonic. The balanced crystalloid are subdivided into hypotonic, like Hartmann solution or Linger lactate, and isotonic, like plasmalide. For the colloids are divided into synthetic colloids, semi-synthetic colloids, plasma derivatives. Synthetic colloids is away of our scope. Semi-synthetic colloids like starch, which is hydroxyethyl starch, dextrans, and gelatins. The plasma derivatives is like the purified plasma, proteins like the albumin 5%, albumin 20%, or the whole plasma products, which is the fresh frozen plasma. So the types of the colloids is semi-synthetic, gelatin, dextrans, starch, plasma derivatives like albumin, and fresh frozen plasma. The colloids gained its popularity starting from World War II, which is invented the dextrans, and previously in World War I, which they invented the gelatins. Gelatins are polypeptides derived from a bovine collagen. Gelatin particles are smaller than the other synthetic colloids with average molecular weight of 35 kilodalton. Dextrans are a mixture of glucose polymers of various sites. They are derived from a bacteria called leuconostoc and have average molecular weight of 40 kilodaltons and 70 kilodaltons. Dextrans are used in very limited seats to improve blood properties for decreasing blood viscosity and increasing microcirculatory flow after vascular surgery. The very famous hydroxyethyl starch, which is now present as 6% 130 over 0.4, is nowadays the famous that are used. But in general, the using of colloids in critically ill is discouraged by randomized controlled trials. Albumin usage in critically ill is used in a very limited cases, for example, bacterial peritonitis, spontaneous bacterial peritonitis, and hepatorenal syndrome, and in replacing paracentesis. Regarding the factors to consider when using fluid replacement solution in a patient, the right fluid replacement solution for a patient involves considering several critical factors to ensure optimal outcomes, like patient's clinical conditions like volume status, either hypovolemia, rapid fluid replacement is required, or hypervolemia, so we should be careful and be monitoring to avoid fluid overload. The second thing is underlying medical condition. Cardiac function like heart failure may necessitate caution in fluid administration. Renal function, impaired kidney function should need choice and reduce the volume. Also liver function have impact on fluid balance and albumin level. The third thing in the patient's clinical conditions that we will depend to choose the fluid replacement is the type of fluid loss. So in blood loss, it is very wise to provide blood products or colloids. Electrolyte imbalance, it is very wise to give a specific electrolyte solution like potassium chloride in cases of hypokalemia. In dehydration, crystalloid like normal saline or lactated ringer is a good choice. The second condition after the patient's clinical condition is the fluid composition and the properties. Either we can give crystalloid or colloids. Crystalloid for general fluid replacement. Colloid, according to the randomized controlled trials, are less discouraged and not given in our ICU nowadays, but it used in very limited seats for rapid plasma volume expansion or specific condition. Also, the electrolyte content matching the electrolyte composition of the patient may need to choose the right fluid. Also, the osmolarity of the patient, the isotonic fluid to maintain the intravascular volume. You can use the hypertonic fluid to decrease the brain edema and the intracellular edema. The administration considerations is the third thing, like volume and rate, and determining the appropriate volume and rate of administration based on the patient's condition and response. Also to monitor the vital signs, the urine output, and the lab values for different electrolyte imbalance. Nowadays, we changed our practice in our ICU and in our emergency department to the pH-guided resuscitation or the pH-guided fluid replacement. According to the pH of the patient, we will give or we will choose the right fluid. For example, if the patient is in a hypochloremic metabolic alkalosis, we will replace with a chloride-rich fluid like normal saline. If a patient is suffering from metabolic acidosis, hyperchloremic metabolic acidosis, we will prefer to use a fluid that has less chloride or no chloride.